I would like to welcome everyone. I am Rachel Lieberman. I'm a director at the University of Chicago Celiac Disease Center. Thank you so much for joining us this morning and attending University of Chicago's Peripheral and Central Nervous System Implications in Celiac Disease Conference. I am here with my fellow directors, Dr. Bana Jabri, who is our research director, and Dr. Ritu Verma, who is our medical director of the Celiac Disease Center here at University of Chicago. I'm going to give you guys a few housekeeping announcements. Throughout today's sessions, we encourage you to use the Q&A function at the bottom of your screen to ask questions during the presentations. All other comments can be placed in the chat. And after this session, please return to the main website and scroll down to the next session to click the yellow button that reads CME session. Click to join. You'll be asked to type in your name, email, and a few other items prior to joining the room. Videos of today's session will be posted 3 to 5 days after this virtual conference, and it will be on the same website that you used to access today's event. You can find more information on how to claim your CME credits on CME and tech support on that main website using the navigation buttons at the top. You can also find tech support email there in the event that you're having any kind of difficulties. And once again, thank you so much. I am thrilled to introduce our medical director, Dr. Ritu Verma.
Good morning, everyone. Welcome. Really, it's a pleasure joining everyone here today. And on behalf of Dr. Jabri and myself, would like to welcome you to our CME symposium today here in Chicago, but welcoming everyone from every part of the world. We really have a great lineup, we think, at least Dr. Jabri and I think. For this first half of this symposium, I and Dr. Lebwal will be co-moderating. And don't think Dr. Lebwal needs any introductions, but just a few sort of comments about Dr. Lebwal. He, of course, received his MD from Columbia College of Physicians and Surgeons, trained at Columbia University, did his residency, was a chief resident there in internal medicine, fellowship, and then faculty, and he's an adult gastroenterologist, a practicing adult gastroenterologist, a fantastic clinician, as I'm sure a lot of people know him from that perspective, but he's also really an excellent researcher. He's an author of many peer-reviewed papers. One of the things that I've also learned about him is besides medicine and research, he's also obtained a master's in patient-oriented research from the Department of Biostatistics. And I think not a lot of us have that. And that's a unique skill that Dr. Lebwal does have. He is chair of the Gastrointestinal Drugs Advisory Committee of the United States FDA, and also has a lot of funded research from the NIH, the AGA, from the CDF, and lastly, but maybe the most important thing, Ben, president of the Society for Study of Celiac Disease. So it really is an honor to be co-moderating this session with Dr. Lebwal. So you'll see both of us back and forth through the morning. So without much further ado, I think what I'm going to discuss is really talk about today's program, and you will hear a lot about where we are with the peripheral nervous system, the central nervous system in celiac disease. And just a few moments, you know, when you go back, so I'm basically a clinician, I'm a pediatric gastroenterologist. When you think about celiac disease, you know, we've gone through from a clinical standpoint, accepting celiac disease is only seen in children and children with diarrhea and weight loss and so on. We accepted that many years ago, and then we sort of learned over time that symptoms can be constipation. You don't have to lose weight, and you really don't need those classic symptoms of weight loss. So again, it took us a little time as clinicians to learn and accept that. But we had some biomarkers we were looking at. We were able to see constipation. We were able to see those kind of things and feel them. Took us some time to realize that celiac disease can happen even if you don't have weight loss. Went on down the line, and then you hear patients talking about different central nervous system disorders, talking about anxiety, talking about brain fog, talking about headaches. And I think it has taken us some time to accept that as part of being part of celiac disease or gluten-related disorders. And you wonder why? Some of it is, I think, when you think about someone going on a gluten-free disorder, you say, well, you know, you're on a gluten-free diet, so you must be anxious, so you must get a headache. We never accepted for quite some time that that is part of this spectrum of gluten-related disorders. And part of the reason is we don't have any objective evidence. We don't have some evidence, or we did not have some evidence to know this truly is related with gluten-related disorders. So what we're hoping today is to start a discussion, learn what's out there, and bring it to the next step of learning, accepting, and then finally knowing how to treat our patients who have these neurological manifestations. So I think it's a learning experience for all of us. So to start us off, we have Dr. Sonia Kupfer, who will be joining us with our first talk, educating us and discussing why the peripheral and central nervous system, what are we going to talk about in terms of the neurological manifestations. And just a little background on Dr. Kupfer. She is also an adult gastroenterologist here at the University of Chicago. She's our Associate Director of the Adult Celiac Disease Center here. She has a lot of different hats that she wears, and I have no idea how she manages it, but just briefly, she's a member of the executive board and director of the genetic research here at the University of Chicago. She, in the past, has served as secretary of the North American Society for Study of Celiac Disease. She has also organized many meetings with the FDA to review endpoints of celiac disease therapeutic trials. She's a fantastic clinician. She's been in the celiac and gluten-free disorders space for quite some time. Not only that, but she also mentors and trains a lot of young fellows and researchers to work in the space of celiac disease and gluten-related disorders. She is an investigator who also initiates clinical trials here for multiple diseases, but definitely for celiac disease. And really, I have no idea, Sonia, how you do all this, but thank you so much for joining us today, and welcome, and get the day started.
Great.
On to you.
Thank you, Dr. Verma, and thank you to Dr. Jabri and our Celiac Disease Center for this opportunity to really dive into an area that I think does not get enough coverage when we talk about celiac disease. So I'm going to get the day started and really to give an overview of the neurological manifestations that we see in celiac, and just touch on some of the research that's been done. I have no financial conflicts to disclose. I do need to disclose that I am a gastroenterologist. I see patients with celiac disease, but I am not a neurologist. So we are talking about neurological disorders, so I just need to put that caveat in. So the key points of my 15-minute talk are that celiac disease has protean signs and symptoms. You've heard this from Dr. Verma. What we thought classically was celiac disease. Now we have many non-classical presentations. I'm going to talk about peripheral and central nervous system abnormalities that occur in celiac disease. And then finally, hope to leave you with neurological manifestations being common, probably more common than we thought in this disease, but really are incompletely understood. And there's a lot of space here to further the science. So to touch on the epidemiology of celiac disease, I'm very grateful to the moderator of this session, Dr. Lebwal, and another colleague, Dr. Alberto Rubio Tapia, who wrote this fantastic review in gastroenterology this year, just summarizing the state of the art in celiac disease. And just some highlights: this is a very common disease with a prevalence of approximately 1%. The incidence and prevalence are rising, and this has been proven now in multiple studies. Celiac disease is seen worldwide, and there was a nice review article on this looking at the prevalence really in multiple different countries and almost every continent. It affects individuals of all ages. I'm an adult gastroenterologist, so I see many patients who are diagnosed well into their 40s, 50s, and 60s. It appears to affect women more than men, although I'll say there are some caveats to some of the research in this area. And the question is always whether women are the ones who come to get diagnosed and men remain undiagnosed. But there are some studies suggesting that women are in fact affected more than men. And as we all know in this area, many of our patients remain undiagnosed, and it takes many years for them to finally get their diagnosis. So what are the classical manifestations? And this was based on a paper in Gut by Ludvigsen and others, including people on this call, who just wanted to get the nomenclature, the definitions right. So the classical manifestations, which we in the past used to call typical symptoms, but we're learning that there are many, many typical symptoms. So now we use the term classical manifestations, and that included signs and symptoms that had to do with malabsorption. So really pointing primarily to the gastrointestinal manifestations. And that would include patients with diarrhea, and in fact, those who were malabsorbing fat, something called steatorrhea, and then had evidence of weight loss or in children growth failure. And this was really how celiac was first described. So this is in Greece, Ereteus described if the stomach be irretentive of the food and if it passed through undigested and crude and nothing ascends into the body, we call such persons celiacs. So you can see that right from the beginning, the gastrointestinal manifestations were first and foremost. But as Dr. Verma alluded to, we know that celiac disease has many, many, many different presentations. And those are now referred to as the non-classical symptoms or manifestations. And that, of course, can include intestinal, but not necessarily diarrhea. It can also be constipation. We know there are bone manifestations, so low bone density, osteopenia, and osteoporosis due to perhaps inflammatory mechanisms, but also, of course, malabsorption. There are skin manifestations, dermatitis herpetiformis being the primary one that is associated with celiac disease. There are reproductive manifestations in terms of infertility. And then what we're talking about here today are the neurological manifestations. And I'm going to be covering that in the remainder of the talk. So the title of this conference is the Central and Peripheral Nervous System. So for those who are not in medicine, I thought it would be helpful to just review what we mean when we're talking about these two different nervous systems. So the central nervous system is really composed of the brain and the spinal cord. This is sort of the central operating system where a lot of the information that comes from the peripheral nervous system is processed. And then the peripheral nervous system is what goes to all the ends of our bodies to provide information about what's going on, for example, in the environment. The peripheral nervous system is further divided into the autonomic nervous system. This is the system that communicates with our internal organs and glands. And that's further divided into the sympathetic, which is the arousing, the fight or flight response, and the parasympathetic, which is the calming response. In addition, the peripheral nervous system has a somatic side, and this is what communicates with sensory organs and voluntary muscles. So we have sensory, which are called afferent in input, which is the sensory input, and then the motor or efferent, which is the motor output. So this is both what we sense and how we move. So what are the manifestations of both the central nervous system and the peripheral nervous system in celiac disease? And this is not an exhaustive list, but this is what I could find in terms of the more common associations that have been reported. And we're going to be diving into some of these in more detail throughout this conference. But just to have an overview in terms of central nervous system manifestations, there have been descriptions of white matter lesions. There's been work in ataxia. This is a very particular movement disorder, and this is particularly affecting the cerebellum. Epilepsy has been associated with celiac disease. And there's a particular condition, which is celiac disease, epilepsy, and then these calcifications, especially in the occipital part of the brain, which seems to affect people and children in particular, and seems to be something familial, and only in certain countries has it been described. So very little known about that entity. Headache, a very common symptom in the general population, but seems to be more common in individuals with celiac disease. And then something my colleague, Dr. Loeffler, will dive into in much more detail is gluten-induced neurocognitive impairment, or as we refer to it, brain fog. And then in terms of the peripheral nervous system, probably the most common thing that I encounter in clinic is individuals who have polyneuropathy. This can be a number of different manifestations, but often people will describe numbness and tingling that affects the hands and the feet. There have also been some reports of autonomic disturbances, so having to do with that fight or flight and calming nervous systems, and then other reports of other neurological manifestations, including myoclonus. So this paper, which was published in 2019 by the group in Sheffield, looked at prospectively 100 patients who were newly diagnosed with celiac disease and really tried to characterize the neurological manifestations that they had at the time of diagnosis. So as you can see, and as I'm trying to talk about, the symptoms actually, the neurological symptoms were much more common than we probably thought. So about 67%, over 2/3 of these patients who were newly diagnosed reported some kind of neurological symptom. And even if you took headache out as one of the symptoms, the percentage was still about 50% with other neurological manifestations. So this is a common condition in celiac disease. And what were the symptoms that were described? Well, I mentioned headaches was one of the most common ones. About 42% of patients reported these. Sensory disturbances, about 12%, and then gait instability, about a quarter of patients. What about signs when they actually looked at objective measures of the neurological function? You can see that about 10% of patients had some kind of sensory loss or areflexia. And then nystagmus was another thing that was found. And then again, this gait ataxia, this movement disorder, this inability to, put one foot in front of the other and be stable. That was reported in approximately 30% of the patients that were studied here. And they also corresponded imaging findings. So they were able to look at these, almost all of them, in terms of abnormalities on brain imaging. So you can see that about almost half had abnormal findings in the cerebellum using this particular type of study. 25% of patients were found to have white matter abnormalities. Remember, that was one of the manifestations that had been described. And they reported that this was statistically significant when compared to healthy individuals in whom only about 3% are found to have these white matter abnormalities. So suggesting there is something in newly diagnosed patients that is affecting the white matter. They then looked at a subset of the patients who had repeat imaging a year later, and they noted that 50%, so these are individuals now on a gluten-free diet for a year, over 50% normalized the findings on their brain imaging. And this particular group in Sheffield is very interested in this transglutaminase 6 marker, and they noted that 40% of those patients had these positive antibodies and that they seem to be statistically significantly associated with brain atrophy. So we'll be hearing more about this particular marker in subsequent talks. Just to go over some of the other manifestations so you have some idea of what has been described and what the prevalence is and how these respond to the gluten-free diet. So this gluten ataxia has been reported in 15% of all patients with these movement disorders, and even higher percentage, 41%, in those who have these movement disorders where there seems to be no other cause. And the response to the gluten-free diet appears to be good, meaning that when patients go on a gluten-free diet, these ataxias or movement disorders do improve. I mentioned epilepsy. The prevalence in the studies has ranged from 0 to 7%. And then this very particular condition that affects children, although rarely, including epilepsy and then these cerebral calcifications. And the response to the gluten-free diet has been variable. Headaches, again, 46% of adults, 25% in children, and there does seem to be improvement on the gluten-free diet, with one study reporting over 75% getting better. And then peripheral neuropathy, about 50% of adults, less common in children. And the response to the gluten-free diet here has been inconclusive. And I'll say that that has been my clinical observation as well. And if it does improve, it takes much longer than some of the other manifestations of celiac disease. Just to drill down on a few of these, so the cerebellar ataxia, the symptoms can be wide-ranging. It includes movement disorders, but it can also affect speech, and it can also affect eye and gaze. So these individuals will have trouble doing a finger-to-nose kind of test. Exam findings will include these abnormalities in the cerebellum, which controls movement. And gluten-free diet seems to be beneficial, although there have been reports of using IVIG in cases where the gluten-free diet doesn't seem to work. And I'll mention that it's also interesting that there have been reports that this ataxia, this movement disorder, doesn't even necessarily have to correlate with enteropathy. And so I think there's some question about what the relationship is with securely diagnosed celiac disease. Turning to headache, this was a meta-analysis, so taking a number of studies and looking in total what the prevalence is. And you can see here, there's a range, of course, from nothing to 50%. The overall prevalence was about 26%. And then when you looked at what was the odds of having headache and celiac disease, that was approximately over a 2.5-fold difference in terms of the odds ratio. And then finally, the peripheral neuropathy, here too, the symptoms can have a number of different manifestations. It's primarily sensory loss, and patients can describe paresthesias, imbalance, even some motor abnormalities. They can have a Guillain-Barré-like syndrome, but motor weakness in and of itself is rare. There are a number of exam findings. I'm not a neurologist, so I can't go into detail on exactly these findings, but I'll say that some patients actually have normal findings as well, and that can be frustrating for them. And I mentioned that gluten-free diet can have mixed results. So I'll finish off just by my key points again, that celiac disease really has a number of different signs and symptoms, and really there's no typical or atypical symptoms. Peripheral and central nervous system abnormalities occur, and these appear to be common, but really incompletely understood. And I'll end with that. We're going to be hearing about brain fog from Dr. Loeffler, but I wanted to let you know, for those on the call, that we are launching a study on brain fog and celiac disease. And we have a survey that you can fill out. And if you're interested, please contact our coordinator, Allie Reynolds. Her email is here, and I'll just leave that up for a moment. And I look forward to the question and answer session. Thank you.
Thank you, Dr. Kupfer, for that whirlwind tour and broad overview, really setting the stage for today's event. So it is my pleasure to introduce the next speaker, Dr. Dan Loeffler. Dr. Loeffler is a practicing gastroenterologist and a founder of the Celiac Center at Beth Israel Deaconess Medical Center. He's associate professor of medicine at Harvard Medical School, where he continues to see patients with gluten-related disorders. Dr. Loeffler is the recipient of multiple grants from the NIH, foundations, and industry for the advancement of digestive health. And he's really working to move forward the science of celiac disease on all fronts. I remember first seeing Dan's name in the development and validation of some of the early symptom scores and adherence scores that's used in hundreds of papers now in measuring the impact of celiac disease, or how strictly adherent people with celiac disease are to the gluten-free diet. And we're still using those to this day. And now Dr. Loeffler, he had joined actually Takeda Pharmaceuticals in 2016 and is currently a senior medical director and a global clinical lead for celiac disease in the gastrointestinal therapeutic area. So we're excited to see in this new era of non-dietary therapeutics, Dr. Loeffler is really moving things forward. Today, Dan will be talking about the topic of celiac disease on your mind, an overview of neurologic complications and comorbidities of celiac disease.
Thanks so much, Ben. And thanks to the organizers for this, Ritu and Bana. As Sonia said, this is really a underappreciated and understudied condition. So Let's just jump in, shall we? So my disclosures are here. I'm also not a neurologist, as Sonia well put. So this is a little out of my comfort zone as well, but I think a really fascinating topic that I've been interested in for quite some time. So just to step back before we get into celiac disease specifically, you know, when we started talking about celiac disease and neurology, and we really, a lot of this came out of Sheffield, and so I'm excited for the talk later today by Dr. Crowell. There was a lot of skepticism about how could celiac disease cause neurologic disorders. You know, it's a GI disorder, right? How is it causing brain? And to some extent, I think the rest of medicine has caught up with celiac disease. And so we now recognize that the gut has a profound impact on neurologic health through a variety of ways, the immune system, the endocrine system, and the microbiome, all of which really change the way the nervous system can function both peripherally and centrally. And this has been associated with a lot of disorders now: cognitive function, pain, mood disorders, neurodegenerative disorders, even cerebral vascular disease. But I wanted to give a couple specific examples that I think shed light a little bit on the different ways that GI disorders and immune disorders can affect the nervous system, which may act as a paradigm for how we begin to better understand what's going on in celiac disease. And I'll run through some of these kind of briefly. First of all, from the IBD literature, there's increasing data, and all really in the last couple of years, that there are structural brain differences in people, especially with Crohn's disease compared to controls, and that these are associated with cognitive differences. And interestingly, it's a little unclear right now whether these are related to the inflammation, to the structural changes of the gut, or to the microbiome changes of IBD. I think the microbiome changes, especially in the small intestine, we're still learning a lot about, but appear to be really important, not only for celiac disease, but some other conditions as well. And one of my favorite examples of this comes from the IBS literature. A lot of this is done at McMaster and the Birchick lab. It's a great example, I think, of bedside to bench, back to bedside research, where they observed changes in the microbiome in people with irritable bowel syndrome. They then were able to alter the microbiome of mice and lead to sort of similar behavior changes, equivalent behavior changes in mice that you see in patients with irritable bowel syndrome. They then took the microbiome from irritable bowel syndrome patients and put it into mice. And actually they used to, maybe they still do, as an aside, have videos of this up on the McMaster website. And really, these mice are fun to watch because they're kind of neurotic little guys running around with no more difference than their brothers than having the microbiome of patients with irritable bowel syndrome. And finally, they did a pilot study of replacing or fixing that microbiome imbalance in irritable bowel syndrome and seemed to have improvements not only on GI function, but really on mood more than anything else. And so finally, the last example that I wanted to give outside of celiac disease that I think sheds a lot of interesting light on celiac disease before we jump into some of the neurologic issues of celiac disease is narcolepsy type 1. So for those of you who are not familiar, narcolepsy is a rare chronic neurologic disorder typified by excessive daytime sleepiness and even cataplexy, where you fall asleep suddenly. And it's been associated with decreased hypocretin, a neurologic hormone. And it's the parallels with celiac disease are really interesting because it has followed very much a similar pathway where it wasn't felt to be autoimmune. And then they noticed a very tight HLA association, which made people think it might be autoimmune. And then they saw an increase, sort of an epidemic of this in Scandinavia, in this case following H1N1 infection or vaccination. But again, it has some interesting parallels to the Swedish epidemic of celiac disease related to infant feeding practices. And most recently, actually just about 2 months ago, was published some work showing that they actually are able to identify autoantibodies and autoreactive T cells in patients with NT1 that cross-react with viral antigens, in this case, the flu antigen. So really, in this case, all you need to do is replace influenza antigen with gluten antigen, and you get the same story of celiac disease recapitulated just in a modern era, really showing how even sort of systemic autoimmunity can lead to very specific and interesting neurologic defects. So given this, I think it shouldn't come as a surprise that celiac disease can have a lot of neurologic consequences. It actually should be expected because celiac disease will change all of these things. It is an antigen-specific autoimmune disorder with likely epitope crossover. There are microbiome changes. There are structural and nutritional changes. So I think we should not look at all these things with an air maybe of skepticism anymore, but of acceptance, and really start to study them more completely. So when I think about the neurologic effects of celiac disease, I find it's helpful to lump them into these two categories. And the first is the chronic neuropathies, the peripheral neuropathies, and CNS changes, including cerebellar ataxia, which Dr. Kupfer just talked about. And then the more transient effects of gluten exposure, headache, which again, Dr. Kupfer just talked about. And most specifically, the one I've really been interested in for a long time is gluten-induced neurocognitive impairment, or brain fog. So brain fog is a common manifestation in many illnesses, right? I mean, I think chemo brain is probably the best known one, but a lot of medications in addition to chemotherapy can do it. Systemic viral infections, if anyone's had the flu or something like that, no one's at their best cognitively when they're actively infected. There are hormonal imbalances, and there's a lot of interesting data in hyperparathyroidism, POTS syndrome, systemic immune conditions such as SLE, and of course, celiac disease. And so I think on one level, there's a paradigm of this brain fog condition can cut across many illnesses, but I think actually this masks a lot of differences. I think that the brain fogs from something like chemo brain is likely to be fairly different than the brain fog that somebody gets when they get exposed to gluten. And I think part of the issue is we really don't have great vocabulary for this. I mean, when patients come into the office, or even when doctors talk about, an issue that a patient's having, we don't talk about, no one comes in and say, my visual constructive ability is off today, doctor. They say, oh, I'm confused, I'm not thinking as well. And so we use these lump terms to describe cognitive function in daily life and largely even in clinical practice. And I think this lack of specificity about how we talk about the neurologic sort of dysfunction and changes people feel when they get some of these conditions, it makes it a lot harder to study. And I think we're learning to sort of improve our vocabulary so that we can study these specifically and understand a little bit more what's causing them and what the impact of these are to patients and their families. So brain fog comes up a lot in celiac disease, as was mentioned earlier. It's probably one of the more common manifestations. There's a lot on this slide, and so I won't go into a lot of detail. This is a conceptual model that was done from many patient interviews in trying to develop new patient-reported outcomes for celiac disease. And it's just starting with that circled box. The highlighted ones are the ones that are reported more commonly and or more severe from patients. The non-highlighted ones are reported less commonly. And you see right away that within the extra-intestinal symptoms, one of the things that come out, not just fatigue and headaches, but is this cognitive problems or brain fog, was one of the most commonly reported extra-intestinal symptoms in people with celiac disease. And even more interesting, when you go down to the impact of celiac disease on people's lives, actually more than the GI symptoms, it's this reduced concentration and the mental fatigue come up as really highlighted areas where people feel like celiac disease and gluten exposure adversely affects their ability to do their daily activities, for instance, in the box on the left, and overall psychological well-being. So there's been a lot of hypothesized mechanisms of gluten-induced neurologic impairment or celiac brain fog, partially because there's not been that much research. But I think we can start to hone in on what is more likely and less likely to be the issue. And I'll walk you through some of that. So people have hypothesized about vitamin deficiencies, antibody-mediated neurotoxicity. So Dr. Kupfer mentioned the anti-TTG6 antibodies that appear to be cross-reactive in celiac disease and certainly have been implicated in cerebellar ataxia and likely are implicated in a wider range of celiac-related neurologic insults. They could be secondary due to gastrointestinal symptoms. If people are, have terrible stomach pain or running to the bathroom, it's not, they're also not concentrating on other things in their life. Or it could be due to circulating inflammatory cytokines. This is not inclusive. There are probably other potential reasons, but I think these are the four that have been talked about the most. So what can shed light on this? And one of the first things is just better assessment of how patients are feeling. So this is a study we did with Jessica Edwards-George, who's a psychology professor at Northeastern, as well as the Beyond Celiac Disease, a really large survey, online survey of patients, mostly with celiac disease, over 1,000 with celiac disease, but a few hundred with non-celiac gluten sensitivity as well. And I know that's a topic that's going to come up later this morning. And just the first thing we did was ask people to actually explain how they thought about brain fog, like what happened to them, how they described the symptoms. And you get an interesting mix of symptoms: difficulty concentrating, mental confusion, forgetfulness, detachedness, grogginess, covered most of these. And I think this really helps us then to refine the type of more sophisticated neurocognitive tests we do to really hone in on these type of issues that people are complaining about. And I will come back to this in a second, because I think it sheds other light on this syndrome beyond just helping us to understand what types of symptoms in a more specific way people are talking about when they say, this brain fog is really bothering me, doctor. So part of this comes, there's been other data that's come out very recently from the UK Biobank, showing that there's also, in a more of a cross-sectional study, differences in people's thought process. And I think this reaction time graph, which was correlated with MRI changes, is also something that really coincides very well with the type of symptoms that people complain about when they're talking about brain fog. And as you see here, patients with celiac disease had significantly sort of slower reaction times than patients with controls. We go forward. So there has been other data. This is a study out of Australia showing that cognitive impairment with celiac disease improves on a gluten-free diet. And in this case, it correlates with histologic and serologic indices of disease severity. However, but not nutritional. They looked at a variety of nutritional levels, and they said right here in the discussion, there really no meaningful pattern could be found between the cognitive test and nutritional levels. So again, starting to cross off what are the more or less likely causes of brain fog from some of these studies. But it is reassuring that people on a gluten-free diet seem to improve, although that improvement was mixed and not everyone did fully, and not every study has shown the same degree of improvement. Another study, again, coming out of Sheffield, showing something a little bit different, where some of these same abilities, visio-constructive, verbal memory, they were worse in celiac disease than healthy controls, but actually seemed to get a little worse with established celiac disease. This is a little bit of an outlier study and something that is concerning, but I think we need to understand better. So I've shown a couple of sort of graphs, and let me go back for a second to this one and this one, where you see things that are reported in the literature as significant differences in cognitive function. But honestly, those box plots don't look very impressive. If this was, a treatment trial of some new medicine, we wouldn't be overly impressed by that degree of separation. But I think what's different about this, and this is something that a psychologist, Robert Lantzman, shared with me, where he put together a whole bunch of different medications and drugs, I guess, and medications, as well as a few other things, and showed the amount of standardized change from baseline you see in a specific cognitive test. And this is really interesting to look at. I'll leave it up just for a second. But what you notice, and I think what the key is that things that we accept societally as important modifiers of cognitive function, so the methamphetamine, Ritalin, which improves school performance, or a 0.05% blood alcohol level, which you can get a DUI for, these have very small changes. So 0.5 or less changes from standard deviation are what we accept societally as really important clinical changes in cognitive function. And I think this is different than what we see with a lot of other things, where a 0.5 standard deviation change really doesn't move the needle much. There are a lot of potential reasons for this. It's sort of philosophical in nature, but I think the one that I think resonates with me that I heard is that for most of what we do, take upper body strength, right? We're not usually using our maximal upper body strength. So if you lost 20% of your, a bicep strength, you probably wouldn't notice for a little while unless you were doing bench presses. But in modern society, we're basically forced to use full mental acuity all the time, whether it's multitasking, doing stuff on screens, learning new technologies, whether it's just our jobs. So we really don't tolerate even mild changes in neurocognitive ability the way we can with sort of more physical functioning. So going back to this survey that was done of patients with celiac disease and non-celiac gluten sensitivity, One of the other key questions that was asked in this survey was, how quickly do symptoms onset when you get exposed to gluten, and how long do they last? And what you see here very quickly is that symptoms come on really quickly, I guess, to use that word again. So usually with the median time was about 30 minutes to an hour time of onset, but the majority of people were having symptoms within 1 to 2 hours of a gluten exposure. These symptoms were peaking 1 to 4 hours later, but generally took a couple of days to resolve. So this shows it comes on quick, but lasts a while. And so even a single gluten exposure can be fairly burdensome if you're not at peak performance for the majority of a week. So I think this type of data gives us some interesting things. So vitamin deficiencies, unlikely, not only because of that one study that showed there was no correlation with vitamin deficiencies and cognitive impairment celiac disease, but also because something that comes on within half an hour, you're not getting a new vitamin deficiency in the first day of getting gluten exposure. You're probably not also getting increases in TTG6 antibodies that quickly. And a lot of these symptoms happen independent of gastrointestinal symptoms. So people report brain fog all the time who don't have any GI symptoms whatsoever. So I think actually it makes these hypotheses and mechanisms of gluten-induced neurologic impairment, it starts to call down the likely culprits. And the one that's sort of left on the board, and I think the one that I think is most likely based on current data, is that acute cytokine elevations are what drives a lot of this brain fog, this acute brain fog that people get with gluten exposure. And so I want to just give some background cytokine data because I think it actually pairs very nicely. And so this is very new data we didn't really know about 5 or 10 years ago. But this came out of a clinical trial for NextVax2 run by Bob Anderson out of Australia, where they had an interesting and unexpected side effect in that this was a therapy where they took artificial gluten peptides, basically synthetic gluten peptides, and gave people shots in the arm with them. And in these, interestingly, they recapitulated people's celiac symptoms. So abdominal distension, nausea, diarrhea, abdominal pain, reflux, all were worse when you got a shot in the arm of gluten, which was really unexpected because we really did believe at that time that you had to eat the gluten, had to go through your GI tract to cause these type of GI symptoms. So diving into this more, what they found was that when people get exposed to gluten, either through a subcutaneous injection in that study, but more typically through food, you get a very quick peak of cytokines. And if you look at these graphs where this is IL-2, but a variety of other cytokines go up as well, you see that it maps very nicely to the type of the onset of symptoms people talk about with gluten-induced brain fog, where within a couple hours cytokines max and then they slowly go back to normal over time. So this appears to be a very celiac specific. You can see in the graph on the left, it doesn't happen with healthy controls. Both celiac disease, to varying degrees, people get elevated in cytokines, and to some extent, the degree of cytokine elevation correlates with some GI symptoms. So I think this is, again, association is not causation, but I think it helps to build this case that, oh, maybe it's these burst of cytokines people get when they get gluten exposure that at least trigger the acute brain fog. But we know that that's just what happens early. And I think we've also some work that we've done recently and published last year on the sequence of immune and intestinal effects that happen with gluten exposure. So you go from this very acute cytokine release, but then later you get an adaptive immune response with gut-homing cytokines, gut-homing T cells running around. And then a few weeks later, you get intestinal damage. And I think one of the interesting things that could be done is we could start to map these type of immune effects of celiac disease onto the neurologic effects. So maybe you do get brain fog within a couple of hours because of the cytokine response, but maybe you get peripheral neuropathy, a couple of weeks later due to sort of autoreactive T cells, for instance. So I think an area that really deserves more study, and I think we're getting the tools to do that. So unfortunately, there's been scarce few prospective studies of brain fog and after prescribed gluten exposure. And I'm really excited for the study that was mentioned earlier by the University of Chicago, where they're actually attempting to do this. I think this will be a really important study. So I encourage anyone who's online to think about participating if that makes sense for you. But this was a study actually out of using non-celiac gluten sensitivity by Dr. Crowell. Again, you'll hear from him later today, so you may go through this. I won't, except to say that there's a very significant change in brain fog. in people even with non-celiac gluten sensitivity after exposure to gluten. So I look forward to seeing this data in celiac disease as well. So just as we start to close up, I think this is the right time to study these things because we have much better tests of cognitive assessment than we used to. These are things that you used to have a long interview with a trained neuropsychologist to understand what people were reporting and how people were experiencing brain fog. But now we've got a whole, interesting toolbox of mostly online, see on iPad version here, online neuropsychological tests, which can really hone in on the type of neuropsychological changes people have with celiac disease or anything else in a way that allows them to do it from home, do it from a clinic without trained personnel, and really sort of democratizes this type of research and hopefully brings it, a lot of these conditions into wider recognition. The other thing that I think may be helpful for this audience is we've also been, as a celiac community, aligning around how best to talk about and understand gluten challenge and gluten exposure in clinical trials. And I think this has been one of the main things that slowed this and many other areas of celiac disease down is a uncertainty about the safety of gluten exposure in a clinical trial setting and their subsequent sort of expected reluctance from patients and even some clinicians to talk about gluten challenge and to consider it for research purposes or clinical purposes. So just to run through this really quickly, I think we've learned now that gluten exposure in a carefully monitored study is safe, but it can cause symptoms, both GI and non-GI, immune activation, celiac serology elevation, and mucosal injury. But importantly, these type of gluten exposure studies do not cause an increased risk of long-term complications. They don't cause any permanent damage to the small intestine. And ongoing symptoms usually resolve very quickly after the study is complete, within a few days. But there are certain cases where we don't recommend gluten challenge. People who are pregnant or planning on becoming pregnant in the near future. Specific for today's subject, if people have a severe celiac-related neurologic condition such as gluten ataxia, or if they have type 2 refractory celiac disease. But outside of those cases, I really think gluten exposure in a clinical trial is super important for helping us to expand our understanding of celiac disease. So to summarize, specifically around the neurocognitive effects of gluten exposure, so I think what we've learned is that gluten-related impairments, so GINI, brain fog, whatever you want to call it, are actually common experiences in celiac disease. And I think people describe them in fairly similar ways overall, but we really do need a more complete examination of the cognitive symptoms from self-report to help understand if these are motor, attention, concentration, or memory as the main areas, and really how these affect people's lives with the ramifications of difficulty concentrating and forgetfulness. I think systemic gut-derived cytokines are likely involved. However, I think we also have to keep in mind, an open mind and think that gastrointestinal sensations and mood disorders may also be involved. MRI data has been very helpful and it suggests subcortical brain regions of the cerebellum and some other areas that are implicated in cognitive function, perhaps suggesting that why some people seem to have more of a sensitivity to brain fog than others. And then just finally, I think we at this point in medical knowledge really should accept that GI conditions broadly can have a diverse effects on neurologic health. And because of this should be expected in celiac disease as well. Neurologic changes from celiac disease range from severe irreversible CNS degeneration, such as cerebellar ataxia, which is fortunately very rare, to subtle and reversible peripheral neurologic and neurocognitive changes, which are much more common. Specific cognitive deficits, such as inattention, executive function, and processing speed, can really affect quality of life and activities of daily living. And even subtle changes, and I think this is really a key point, even subtle changes can be burdensome and affect school, work, and daily functioning. And we should try to do a better job, and I'm guilty of this as well, of assessing this better in clinical practice. And as I already mentioned, more studies, as always, are greatly needed. So I will stop sharing my screen and interested in the questions. Thank you all for your attention.
Thank you so much, Dan. So we now have a few minutes for a Q&A, and I encourage attendees to use the Q&A feature in your Zoom webinar. And I'll start by asking a question that was asked by one of our attendees, really about terminology, the term gluten neuropathy. So does everyone with celiac disease and neuropathy, should they be termed as having that? Or is that celiac associated neuropathy? And then we use the term gluten neuropathy, for those with, ongoing neurological symptoms and or those who might not have enteropathy, maybe not even celiac disease, but have a separate condition wherein gluten is driving neurological damage outside of enteropathy. An easy question.
Yeah, I was going to say, as that question went on, it got harder and harder. Where to even start? So, I think this is an issue with, overall is that, celiac disease has diverse manifestations, but also people with celiac disease have other conditions. And so what, is headache, is somebody with celiac disease related to celiac disease or is it not? And so I think, part of it is, understanding a temporal relationship. If somebody has peripheral neuropathy and it goes away on a gluten-free diet and comes back with gluten exposure, then I think we could, clearly say that is a celiac-related peripheral neuropathy. Some people, it's just going to run another course, right? There's lots of celiac patients with type 1 diabetes. It's its own risk factor for peripheral neuropathy. So I think once we find somebody with peripheral neuropathy, then the next step is, what does it do to? Is it celiac disease or is it something else? And so I think that really has to be done on an individual case-by-case basis. I think for people without celiac disease who have neurologic disorders, but that appear to be related to gluten, I think this is a much more nebulous issue, and one that, to be honest, I was actually even skeptical of, but I think that some of the data coming out about non-celiac gluten sensitivity makes us keep a very open mind about the potential neurologic impacts in at least some people of gluten when they don't have, standard adaptive immune celiac disease. So, I hope that's helpful, but it's a good and very challenging area.
So Dan, thank you very much. And, as I'm looking at these questions and even listening to your talk, I think we have more questions than answers right now, which is good and bad in the sense that at least we are questioning things. And then hopefully by the end of this program, we'll have some direction. I don't know if I'm going to promise answers, but I guess at least we'll have some direction of where we need to go. So one of the questions in the chat, in the Q&A is from a neuropsychologist. And what I'm going to do is take the liberty from a moderator standpoint, and we'll table this question maybe when we have a Q&A at the end of this morning session as well, because then we'll have had a chance to hear a lot more people, and we'll bring this question back. So I apologize, Juliana, but we will bring it back at the end of our session. So one question that has come up, Dan, and maybe the three of us can tackle it a little bit, but it says, do the studies of effect of gluten exposure to brain fog, does it matter what kind of gluten? Does it matter if it's oats versus wheat or barley? Any ideas? I mean, do we know? Is that something we should be looking at? Or will it be answered anyway because you're going to look at celiac disease and have wheat and barley looked at it, and maybe the oats is another story? But what do you think, Dan? And maybe Ben, your ideas as well.
Yeah, I mean, so almost all gluten challenge studies outside of specific ones to look at the safety of other grains have been using wheat gluten. So I think it's a good question. We don't really know if other types of grains would have similar effects. I think if we implicate though the immune response to these immunogenic gluten peptides as the causative factor, you'd expect that any of those that have enough similarity to trigger celiac disease would trigger similar effects, but there could be differences. And I think that is an interesting area that probably does need a little bit more attention. I don't know, Ben, what do you think?
Yeah, I agree. The type of gluten source hasn't really been looked at. My gut instinct is that it's much more likely quantity as opposed to type. So a large gluten exposure will have a very different effect on someone neurocognitively than a trace or small gluten exposure. So Dan and Ritu, I'm wondering, there was a question about considering the psychological background of a person and anxiety. And I think it's important to think about that and comment on, anxiety and also vigilance. is the sleep pattern and quality in people with celiac disease different? There was a study years ago that showed people with celiac disease undergoing procedures actually need more sedation than comparable controls. And maybe the vigilance associated with needing to always be thinking about gluten sources every day. Could that somehow be mediating some of the more longstanding symptoms like brain fog, headache? I don't know if sleep quality has been looked at in celiac.
Yeah,
So I think, it kind of goes back to the discussion of how much do we believe in this and what do we have as far as objective data. I think if you have a baseline anxiety personality and you have the genes and everything else associated with anxiety, probably if you're going to have neurological symptoms, they're going to be worsened. I mean, if I think about from a pediatric standpoint, that they may be enhanced, your symptoms might be worse than others. And the same thing with hypervigilance as we educate our patients in cross-contamination and so on. So to some extent, we are responsible for some of that hypervigilance as well, and that creates anxiety. I mean, that's a normal thing. But I do think that some of the things that we'll be hearing about, also Dan mentioning about cytokines and really getting objective data. So do we look at those cytokines in people baseline before, you get diagnosed with celiac disease, you check those cytokines, you check a neuropsychological profile, and then follow them over time on a gluten-free diet. And see what happens. And I know that with the adults in our study here at University of Chicago, we are also talking about a challenge. But how about we look at it differently and see, and maybe then we can answer the question of how much is baseline anxiety going to really affect that. But I don't know, I'm sort of hoping that we'll be able to have some direction there. What do you think, Dan?
Yeah, no, I mean, I think that you put it very nicely. I don't have anything to add to that. Completely agree.
And I know we have lots and lots and lots of questions here, but we also have a little time crunch. And I think both Ben and I are being warned by our people running this show here that we need to, I guess, probably stop here. Is that where we are at, Ben? So what we will do is we will be taking pictures and shots of all the questions that are coming through. If we cannot answer these questions in our next Q&A, I take the responsibility that I will work with the whole team that will be working today from all the centers, and we will come up with answers and respond to each person. I don't promise it'll happen today, but I promise it'll happen within a week, that we will get to each one of these questions to the best of our abilities.